representatives of co-sponsor agencies for global health scaling up, Ms. Mariana Fara of ISAGS, David Becca, COFEPRIS, Filippo Iare, Senior Program Officer of the Global Fund, distinguished delegates to the Global South-South Development Expo 2014. On behalf of the Director of the Pan-American Health Organization, Dr. Carissa Etienne, I would like to thank you, and in particular the Office for South-South Cooperation of the United Nations, for the invitation to open this session on global health scaling up of South-South and triangular cooperation. Since the adoption of the Buenos Aires Plan of Action in 1978, the concept of technical cooperation among developing countries has been evolving, with South-South cooperation and triangular cooperation being seen as increasingly important modalities in countries' achievements of their development goals, including those related to health. The 2011 Busan Partnership for Effective Development Cooperation stated the intent of participating countries to broaden support for South-South and triangular cooperation, to tailor horizontal partnerships in response to the diversity of country contexts and national needs. The Pan-American Health Organization has used triangular cooperation as a key component of its technical cooperation with countries in health for many years. Unique among the regional offices of the World Health Organization, the Pan-American Health Organization has established budgetary lines to fund what we call TCC projects, Technical Cooperation Strategy Projects, and has promoted and shared experience in these projects at the regional and global levels. Level of development of many of our member states, their installed capacity in health, and their participation in sub-regional integration mechanisms, member states expressed the desire to learn from and work closely with each other in South-South cooperation. The 52nd Pan-American Health Organization Directing Council in September 2013 approved a policy and a resolution on cooperation for health development in the Americas. This resolution calls on member states to initiate, lead, and manage cooperation initiatives for health development and continue ongoing efforts to strengthen national capacity to participate in international health cooperation both within and across the region in coordination with PAHO. It also calls on member states to promote and intensify ongoing initiatives to share good practices and experiences that form the basis of exchange and collective learning among countries, including the sharing of methodologies for the assessment of those cooperation initiatives. In light of this commitment of the Pan-American Health Organization and its member states to move forward in strengthening South-South cooperation, we really do look forward to hearing the experience in these panels today and to support the outcomes of this very exciting event. I thank you very much.
Thank you, James, and good afternoon, everybody. In the interests of time, I'm going to invoke an African saying, which is all protocols observed. It's good to see you all this afternoon, and thank you very much for giving me the opportunity to say a few words on behalf of UNAIDS and my Executive Director, Michelle Sidibe. Let me thank PAHO and the Global Fund for convening this meeting on what I think is a really important, broad and exciting agenda as we look forward. When I was thinking about this, I was reminded to an experience I had back in the mid to late 80s, I think. I was working for the British government, working in marine sciences at that stage. And I think the government of South Africa had asked us to send a team to help them go and look at their coastal zone management work. And we sent a team. And I remember the team came back to London and briefed us, and we asked them how they got on. And they said, actually, there's an awful lot we can learn from South Africa. And I was very heartened to see that many of our own policies and programs changed as a reflection of that interaction. And in the years to come, we did quite a lot of work. I guess you would call it triangular cooperation, where we joined up what South Africa was doing with other programs that we were supporting. I was also in China a few years ago talking about health diplomacy, and I learned so much about their 6 decades of experience of investing in healthcare across the continent of Africa. So this is not a new agenda, but I think it continues to evolve and grow. And I think one of the challenges we have is to figure out the ways in which we can manage, support, and harness this, and what our individual and institutional roles are within this broad agenda. The world is changing rapidly. Maybe that's a truism, but the geography of poverty is changing. Where poor people live, it clearly changes. 70% of the world's poor now live in middle-income countries. And just think about one trend, this greater access to broadband, to mobile telephony, to smartphones, and to social media. And just think about the world's population. The biggest population in any nation, China. The next one, Facebook. The next one, India. The next one, Tencent, WhatsApp, USA, Google, LinkedIn, Twitter, Indonesia. So just thinking about the ways people connect, communicate, think is changing. Ideas and innovations can come from so many different places in the world today. So we're thinking about health and health at scale. And the world's eyes are very much focused on West Africa at the moment as we focus on this terrible scourge of Ebola and the challenges that brings to individuals, to families, to communities, to nations, and to the world. And only for the second time has the Security Council looked at a disease as a security threat. So health and security, health and development are inextricably linked. And yet we've seen 15 years of progress. We've certainly had scale in health. There are many that look at the health sector and say, you've had your turn, you've had greater investments, you've made progress against many of the MDGs, some more than others. We've seen the creation of new institutions and new partnerships, new public-private partnerships, and I think there's a growing recognition and an understanding of the crucial role that the private sector has and will continue to play. And it's great to see Gary Cohen here from B&D, because I think looking to the future, we can't have conversations without the private sector there. And also increasingly the role of civil society. So this is no longer the purview of just governments. And as the world negotiates what comes after the MDGs, the post-2015 development agenda and sustainable development goals, there are some real differences from that MDG era, I think. It's an intergovernmental process, which has its excitements and some challenges. It's an agenda that is intended to be universal, not a north-south development agenda, but a universal agenda, an agenda that looks to integrate the 3 pillars of sustainable development, the social, economic, and environmental dimensions. And we have the beginnings of a framework that is emerging out of New York, but a lot more work to do on means of implementation, on indicators, on finance, on data, and on accountability. And that finance is changing too. This will not be an agenda that is an ODA agenda. It will be an agenda that needs to look at all flows of resources, private, philanthropic, remittances, domestic, but might also want to challenge the scandal of $1 trillion of illicit financial flows globally. So we've seen South-South cooperation in the realm of HIV/AIDS really move the curve. I think one of the greatest illustrations of this is the shaping of the markets for antiretroviral treatment. We saw the price of treatment fall from $10,000 per patient per year to somewhere around, depending on how you measure it and what gets captured in there, around $100 per patient per year. And the role that generic manufacturers, and particularly Cipla and others in India, had in this have really, I think, shifted the response. The response suggests we will have 15 million people on treatment by 2015, a target that just 5-6 years ago people said could not be done. The next 5 years will determine whether we end AIDS as a global public health threat by 2030. And a large part of that will be how we harness and apply the ideas, experiences, and lessons from across the globe. So thank you very much. I'm delighted to be here. I very much look forward to the presentations and the conversations. Thank you.
So thank you very much, Simon, for those remarks. We're going to move straight into the first panel, Scaling Up Projects. And in this panel, we've got 4 distinct presentations for your consideration. We're going to be looking at how, through South-South cooperation and triangular activities between institutions, between member states, between countries, between networks, that we're building knowledge, experiences leading to the development of strategies that ultimately improve health outcomes. So without further ado, I would like to introduce you to Ms. Mariana Faria, who is the head of office of ISAGS, the Institute of Government and Health Union of South American Nations. Ms. Maria is a lawyer specialized in health law with a master's degree in public policies and health at the National School of Public Health, Sergio Aruca, ENSP in Fiocruz in Brazil, in Rio de Janeiro. She is currently the head of office of the South American Institute of Government and Health, ISAGS UNASUR, and is a member of the scientific committee of the Bachelor of Interdisciplinary Management Services in Primary Health from the McBurney Program and McGill Institute for Health and Social Policy. So Mariana, I will hand it over to you for your presentation.
Well, thank you very much, James, and it's a pleasure to be here representing the countries from South America. We have been working very hard in South America since 2005, when UNASUR was created by the 12 countries to bring up more South-South cooperation in the South America subcontinent. And ISAGS was created in this movement of South American countries, and it's part of its Health Council. So what we're going to present today is a little bit about this institute as a tool for the countries of South America to share, to cooperate among them, and also a pilot project on children's health that we have Dr. Liliana, who is going to be presenting specifically about that, which comes from an initiative of the government from Brazil. So, just to give you a brief idea of ISAGS, the South American Institute of Government in Health is a public intergovernmental entity which is part of the South American Health Council of the Union of South American Nations, UNASUR. This institute was created by the 12 ministers of health because the heads of states of the 12 countries in South America decided that health, along with defense, were the most strategic areas of the 12 sectorial areas that are developed in UNASUR. So ISAGS is the result of the political convergence process reached by the countries of the region and the political acknowledgement of health as a key issue for regional integration as well as for development in South America. ISAGS articulates agendas, discussions on regional and global health policies, and has become a privileged space for collaborative work and cooperation. All the decisions at UNASUR are made by consensus, and that takes time, takes information, takes dialogue. So having a tool as an institute, a think tank on health, to research, to gather people, specialists, and to join ideas and possibilities is a very important step for UNASUR countries ahead of development and health access. ISAG has a flexible and concise structure. Our headquarters is based in Rio. It was inaugurated in July 2011, so ISAG is a very new institution, and therefore promotes the concept of networking. We have been working with institutions, academic institutions, but also other intergovernmental institutions. We are here because we have started 2 years ago a conversation with the UNESCO, and so we have been doing that with many other institutions inside South America, but outside South America. And we are always aiming at partnerships with global institutions and specialists that can share with South American countries the best practice. The activities developed by ISAGS are based on the construction of mutual trust, solidarity, and respect, and on the identification of strengths and weaknesses in the region. As its first work, during its 1.5 years of work, ISAGS worked with the 12 countries of South America to build this book. But the book is not the end of the project, but the start, because besides having the 12 health systems written by their own ministers of health, which empowers the countries of South America, we also identified strengths and weaknesses in each of the health systems of the region. And those strengths and those weaknesses allowed ISAGS to construct its plans of work, and on that we can identify which countries can help, can offer cooperation, and which countries need cooperation based on health needs and demands. With the objective of making available to health ministers of South America the best practice and evidences that qualify health management and governance. So ISAGS has been working based in 4 strategies that I would like to share with you this afternoon. The first one is the generation, production, and dissemination of knowledge. This is very important for South America, where 9 of the 12 countries speak Spanish, and many of the knowledge that is around the globe, it is in English. So it's important to produce and disseminate knowledge as well in different languages, but also empower and allow countries and their specialists and investigators to produce knowledge from the region to the region. The second strategy is the contribution to the democratization of knowledge and information access. As Dr. Bland said before, now we have multiple networks and spaces where we can share knowledge. So ISAGS is in the networks that you have mentioned before in 3 languages. We are always publishing all the knowledge that we have been able to produce, but also to manage in Portuguese, Spanish, and English. And we have a powerful website with videos and books available. All our material that is generated is also online. The third strategy, which is very important, and we have heard here before about the need for health workers, is the support to training of strategic human resources. Next Monday, ISAGS is going to start its first course. It's going to be on e-learning basis, but also with some presential face-to-face meeting. And we always like to think that health, or most of the problems of health, do not solve inside health ministers. We need intersectorial action. So that's why our 4th strategy is the intersectorial articulation. That means that we have been working with different ministers in the South American countries, like ministers of social development, ministers of technology and innovation, and but also we are going out of the region and in the region to look for the best practice. If we can find them in one of the 12 countries of South America, we will get that experience, we will get the best practice and try to share it and stimulate South-South cooperation among the other countries. But if it's a need for the whole region and we cannot find that inside the region, then we have to look outside the region, and we have to look for South-South and triangular cooperation to fill the needs and the demands of the countries. And one of the identified needs is the child health, which is a priority for development. I got a sentence from UNICEF that tells us that children are central to sustainable development. I don't think that anybody in this audience would disagree with that. And here we have some data, but the important thing here, because I want to handle the word to Dr. Liliana Lugarinho, who is from the strategy that she is going to explain about from the Brazilian government, is that the investment made on first years of child is directly related to development, productiveness, and prosperity. But it's not for the future. That is one important thing. Investing, because it's not spending, it's not donating. Every time we put money in health, we need to understand that we are investing, because it's an investment on development, it is an investment on the growth of our countries. And doing that in child health means a better world now in the present. It's not just future generation, but it's also a enabling countries to have better health now. So I give the word to Dr. Liliana so she explained to us a little bit about the Healthy Brazilian Kids Strategy, a contribution to reduction of health inequities. Thank you.
Thank you, Mariana. Good afternoon. And okay. Continue.
We need the PowerPoint here, please. No, they just need to put it. Okay.
Okay.
Oh,
Yep.
you pass it to me. Let me go back for you.
Yeah, okay.
Okay. Here you go.
Okay, thank you. Okay, now. The Healthy Brazilian Kids Strategy is an initiative of the Fernandes Figueira de Fiocruz Foundation in collaboration with the Ministry of Health, the General Coordination of Children's Health and Breastfeeding. One of our main concerns is to highlight the importance of mental health, emotional factors and social determinations in children's health in order to contribute to full and healthy development of citizens and their countries, as Mariana has told. Our work today consists in the capacity building of managers of the field in children's health in all Brazilian states and capital cities as multipliers of an integral and intersectoral care for children. The strategy follows the WHO and the National Commission of Health Determinants recommendations to prioritize children's development in order to reduce social inequality. We have three theoretical pillars that are cartography, care, and groupology. I'm going to focus in cartography. That is the most important tool that we have. We want to identify social equipment available in every location in order to extend the care for children. So a professional who can favor articulation between the areas and have such equipment available. It's important to see that we focus our work, we propose mostly in two areas, human resources and leadership and governance. We propose that health professionals who take care of the children's health work together with educators and social workers in order to join efforts obtaining more effective work and better care of children. And how do we do it? Okay. With an e-learning platform. We have a pedagogical proposal, not restricted just to mere teaching tests, but supports the consultant on the change of practice. Each one of the managers of the states and capital cities have a group of them have a tutor that maintains every week and sometimes twice a week direct working about their problems, the main goals, the difficulties they are having in each territory. Face-to-face meetings. We have 3 per year organized as thematic workshop. We work for 4 days. One of them is just for the building capacity. The others are the themes that they need more for the practices in the field. And our methodology is based on the concept of problematizing teaching, inserted in a critical way of seeing the reality and no superiority of the educator over the educated, and with significant learning, meaning what? We are interested in the previous experience and in the personal experience of the people that are working with us. I'm very happy to tell you that after 3 years of working together with those managers, we have been approved our public policy in children's health, that it wasn't a need for all Brazil. If we think Brazil has a population of over more than 200 million people, and just children under 5, we have 13.4 million. And we didn't have a public policy. Also, we work even with the PAHO personnel and all the managers and all the another Ministry of Education and Social Work together. And now I'm showing our proposal. We are proposing a pilot project next year in Bolivia. And as you can see, the mortality rate in Latin America, 2012. And then why choosing Bolivia? The main challenge are related to the maternal child problems. Has the highest child mortality rates of all South America is 50 per 1,000 live births in 2012. The mortality rate has dropped, but still the most important. Has inequalities between urban and rural areas, has inequality in short stature with mother with lower levels of education and children with mothers that have a higher level of education. Chronic malnutrition is a really huge problem, about 46% in the poorest quintile against 6.5% in the richest quintile. And what we are planning, okay.
It's the last one.
It's the last one. In short term, we want to support managers and the formulation of flows of integration of services aiming at a more efficient system through the establishment of intersectoral cores, care for the caregivers, we said cuidar del cuidador, because we understand caregivers are all people, all the professionals that are in, doesn't matter if it's the nurse or is the manager in the field. Everyone must be a caregiver. Strengthening the connection among professionals and the professionals with the family members. And in the medium term, we want to contribute to the diminution of child mortality in the chosen territory with the formation of multipliers of those actions in the country.
So we would like to thank you in the 4 official languages of UNASUR. Thank you, gracias, obrigada, thank you well. We are up downstairs with a booth where we can talk more and share more experiences from UNASUR besides the child mortality. Thank you once again.
Thank you very much, Mariana and Liliana. And I think you probably realize by now that Dr. Liliana Nogueirinho is the Executive Director of the Brazilian Healthy Kids Strategy. So thank you for that wonderful presentation. I think we look very much forward to seeing the outcomes of the South-South Cooperation Initiative between Brazil and Bolivia with regard to the implementation of that strategy in Bolivia as well. I'd like to now invite Dr. David Baca to provide us with a short presentation. David is the Executive Director of International Affairs at the Federal Commission for the Protection Against Sanitary Risks, namely COFEPRIS in Mexico. It's the National Regulatory Authority for Mexico. David holds a master's degree in development economics and has worked previously in the Ministry of Finance in Mexico as advisor in social program budgets. He's also worked in the UNDP program in Mexico in the Human Development Office. David?
Thank you, James, for the invitation and for the introduction. I'm going to pass to go through the exposition in Spanish because I express by myself better in Spanish, but the presentation is in English, so I think it's not going to be so different. Gracias. ¿Por qué nos parece importante estar aquí? Como lo mencionó el doctor Fitzgerald, nosotros somos la agencia regulatoria en México, digamos, somos la FDA mexicana. Y el mandato constitucional que tiene COFEPRIS como tal es dar a la población mexicana productos seguros, de calidad y que sean eficaces. Entonces, ¿por qué estamos envueltos en un programa de cooperación regulatoria regional junto con las otras agencias en América? Bueno, mucho se explica por, primero que nada, la ayuda de PAHO, específicamente del equipo del Dr. Fitzgerald, y adelante voy a explicar cuál es el objetivo de esta cooperación regional. El doctor James y su equipo nos hicieron favor de pasarnos estas láminas que tenemos a nivel regional, donde se muestra una clara debilidad de nuestras capacidades regulatorias en temas de medicamentos y de insumos para la salud a nivel regional. Menos del 70% de los indicadores básicos de regulación en tema de medicamentos los cumplimos como región, y si pueden ver en la gráfica de abajo, solo 9 de las 25 agencias sanitarias hoy cumplen con el 95% de la capacidad, digamos, completa en lo que es la regulación de medicamentos, la regulación básica de medicamentos. ¿Y qué estamos haciendo no para fortalecer a las agencias y fortalecer la regulación en la región? Estas 7 agencias que vienen mencionadas a la mitad de la lámina, Argentina, Brasil, Canadá, Colombia, Cuba, México y Estados Unidos, cuentan con la certificación como agencia reguladora regional por parte de PAHO, es decir, una vez que PAHO ha auditado nuestros procesos, nos ha dado esta calificación como una agencia regulatoria de referencia en la región, y nos ha llevado a tener proyectos de fortalecimiento con cada una de las agencias que vemos en la parte de arriba. Me parece que son 15 agencias, con la organización de PAHO, y más adelante lo vamos a ver, en temas específicos sobre los procesos regulatorios que las agencias sanitarias deben de tener. Desde luego, esto no significa que las otras 7 agencias estemos graduados en temas de regulación. Cada una de nosotros llevamos un proceso con PAHO de mejoramiento continuo, inclusive después de haber tenido la certificación. Y bueno, abajo aparecen 3 centros de colaboración que PAHO tiene para ayudarnos regionalmente en el cumplimiento de nuestras tareas. Bueno, escogimos estas 4 guías que PAHO ha construido para darles más o menos un ejemplo de cómo está la situación regulatoria en América. Aunque hay algunas líneas que hemos implementado de manera regional muy bien, como lo pueden ver ahí en las buenas prácticas de manufactura y las buenas prácticas de laboratorio, por otro lado tenemos una tarea muy importante en procesos dentro de la regulación que son fundamentales para darle a nuestra población medicamentos seguros, de calidad y eficaces, ¿no? Vemos del lado derecho, el cumplimiento de las buenas prácticas de nuestros laboratorios, de los laboratorios nacionales o de los laboratorios de referencia para cada una de las agencias, las buenas prácticas de manufactura, como la agencia revisa que el medicamento esté siendo producido en una fábrica o los insumos estén siendo producidos en una fábrica que cuenta con las buenas prácticas. Y después tenemos el otro extremo, ¿no? los medicamentos falsificados y la implementación de los requerimientos de equivalencia, en los cuales, a pesar o con todo y que contamos con la ayuda de PAHO y la ayuda de estas 7 agencias que tienen la señalización de PAHO de que ya han cumplido con la mayoría de estos estándares, aún en la región estamos muy por abajo de lo que pudiéramos esperar o de lo que deberíamos de ofrecer. Y esto nos habla, viene muy relacionado con las prioridades que tienen las agencias sanitarias en nuestros países. Un poco hablaba con el doctor Fitzgerald y con su equipo en la mañana sobre las prioridades que tienen cada una de las agencias y cómo vemos que, aunque nos falta el 30%, más del 30% de los indicadores básicos que debe de cumplir una agencia reguladora para entregar a su población este tipo de insumos, hoy las agencias reguladoras están envueltas en procesos que como tal no son solo básicos, sino que van más allá, ¿no? El de medical devices y biotecnología, y biológicos y vacunas, y los medicamentos de síntesis química, que a final de cuentas son los medicamentos que más revisamos y los medicamentos que más están entre la población, tienen una categorización menor dentro de las prioridades. Y así también para los procesos. Tenemos procesos muy sencillos que no hemos podido terminar de cumplir o en donde hay una debilidad regulatoria en la región y, sin embargo, hay una preocupación por cumplir procesos de bioequivalencia y biodisponibilidad que quizá podrían ser una prioridad secundaria a la hora de hacer esta regulación. Y bueno, en concreto, la invitación a COFEPRIS, a la Agencia Reguladora Mexicana, es un poco platicarles qué se ha hecho en ese sentido una vez que nosotros hemos obtenido la certificación por parte de OPS y que hemos hecho en cooperación regional y específicamente en un programa que ha tenido mucho éxito en algunos países y que nos ha llevado a tener una fortaleza regulatoria en la región con muy buenos resultados. Un poco esta lámina es para introducir qué es COFEPRIS y en qué estado está COFEPRIS. Hasta 2001, COFEPRIS no existía en el aparato del sistema de salud de México, no había una FDA, así lo podemos decir, en México. Y esto arrancó hasta 2005, cuando se reformó la Ley General de Salud, y hasta 2011 es cuando empezamos con la necesidad de tener una auditoría, una certificación de alguna agencia a nivel internacional que nos pudiera decir que estábamos haciendo las cosas bien y que le pudiera dar la garantía a la población mexicana de que los productos que tenían un registro sanitario de COFEPRIS eran seguros, eficaces y de calidad. Y es cuando entra en el 2012 el término de nuestro proceso con PAHO, que nos reconoce como una agencia regulatoria de referencia y que seguirá con nuestra próxima recertificación en algunos meses. Y en 2014, apenas en julio, la declaración por parte de la Organización Mundial de la Salud a COFEPRIS como una agencia funcional, este es el nombre que ellos le ponen, en los procesos también de vacunas. Ahora ya éramos agencia reguladora de referencia. ¿Eso qué significaba para nosotros? Bueno, que los medicamentos que pasaron por el proceso regulatorio de COFEPRIS eran seguros para nuestra población. Sin embargo, y como PAHO bien lo hace, esta certificación también tiene un componente de ayuda internacional y de cooperación internacional. Y uno de los puntos que nosotros encontramos y cuando nos acercamos a otras agencias era esto a lo que me refiero en el primer bullet, que esta certificación le podía servir al registro sanitario de COFEPRIS como un sello de calidad en los medicamentos que ya habían pasado por nosotros y podía resolver retrasos o debilidades en sistemas regulatorios de otro país. Junto con las otras agencias reguladoras, nosotros hacemos cooperación a nivel de América, junto con las agencias que ya les había comentado, y empatamos esto con un programa nacional, no solo del gobierno que entró en 2012, sino del gobierno anterior, para dar acceso a la salud a la población mexicana. Nuestra parte dentro de este programa era dar acceso a la población mexicana a los medicamentos genéricos que fueran de alta calidad y que fueran más baratos. Como tal, hoy el registro sanitario, debido a esta cooperación regulatoria, hoy el registro sanitario de COFEPRIS es aceptado en El Salvador, en Panamá, en Costa Rica, en Chile y en Colombia. En Colombia es un caso aparte, Colombia como un acuerdo en las dos vías. A Colombia también es una agencia reguladora nacional y como tal hay una confianza dentro de las agencias de que los procesos son muy bien hechos dentro de ellos y que nos ha llevado a que el registro sanitario de COFEPRIS sea aceptado en Colombia o pase por un proceso más rápido en Colombia, más bien dicho, y al revés también, el proceso de INVIMA, la Agencia Sanitaria de Colombia, tiene un trato más rápido en México. Este es más o menos el esquema de cooperación que tiene hoy implementado COFEPRIS para el registro. Recordamos que solo estamos hablando para el registro sanitario. Con Costa Rica está en el proceso de implementación, con Ecuador, con Panamá también está en el proceso de implementación. Con Chile ya tenemos acceso al mercado público y quería dejar al final el caso del Caribe porque no lo voy a mencionar, lo voy a mencionar más adelante porque es otro proyecto que tiene la OPS junto con otras agencias. Y en El Salvador me gustaría mencionar este caso. El Salvador hace año y medio tenía un problema de desabasto de medicamentos. Hoy hay entre 140 y 160 medicamentos con registro sanitario de COFEPRIS que están circulando en Ecuador y que han bajado significativamente los precios en Ecuador y que han resuelto, gracias a este programa, han resuelto el problema de abastecimiento que tenía el sector público en Ecuador. Estoy ahora mencionando un poco otros programas de cooperación regulatoria que tenemos en el marco de las ARNs. No los voy a mencionar todos porque ya me sacaron la tarjeta amarilla, pero son todos programas que llevan al fortalecimiento de las agencias regulatorias como tal, el que ya les mencioné entre México y El Salvador, el compartir los GMPs entre las ARNs, y los reconocimientos unilaterales que hacen muchas agencias sobre los procesos regulatorios, no solamente con FDA, en este caso está el de FDA y Costa Rica, sino también con otros países. Nuestra reunión de fortalecimiento regulatorio en Canadá, que se lleva año con año, y todos los programas de medicamentos falsificados que tiene cada una de las agencias. Desde luego hay prioridades dentro de cada agencia y como ARNs nos hemos ido especializando en algún punto del proceso de regulación que nos lleva también a tener regulación más fuerte. Los programas de cooperación entre las ARNs y las ARNs a nivel global, un poco lo que comentábamos ahorita. Le paso más rápido porque les quiero comentar sobre el sistema regulatorio del Caribe. Debido a las especificidades que tiene los países del Caribe, encontraron que era para ellos una muy buena opción tener una unidad regulatoria regional como el Caribe, y es algo que está trabajando, si bien entiendo ahorita, la oficina de PAHO muy fuerte con este CARICOM en el Caribe y con el apoyo de alguna de nuestras agencias, específicamente creo que ANMAT en Argentina y FDA están muy involucradas. México se está involucrando para que puedan tener, y digo por las propias características del Caribe, también EMA, la agencia regulatoria de Europa, está muy metida en este programa, y esperamos que una vez que se haya implantado el CARICOM en todos los procesos, también va a haber un reconocimiento de los registros sanitarios de las ARNs. Voy a pasar rápido por esta lámina, es la última, es mi último minuto también. Y esto sería un poco platicarles ¿Cuáles son los puntos hacia donde va esta regulación? La priorización de la regulación en los sistemas legales, que es donde hemos encontrado también mucho retraso dentro de nuestros países. La cooperación con las ARNs, que es en lo que estamos trabajando. La armonización, bueno, que es un poco lo que les platicaba sobre, por ejemplo, lo que hacemos Colombia y nosotros, que ahora también va a empezar una implementación con Chile y con Perú, y que están haciendo los países del Caribe. Bueno, me quedaron 2 bullets, pero muchas gracias.
So thank you very much, David. A very interesting experience on how, I suppose, building confidence between member state regulatory authorities begins to leverage sharing information, sharing confidence, and sharing, advancing towards, I suppose, combined regulatory decisions in the interests of public health. Now I'd like to move on to our presentation from the Global Fund. Mr. Filippo Iarrera will present it for us. I hope I've pronounced that correctly, Filippo. Filippo started to work at the Global Fund to fight AIDS, tuberculosis and malaria in 2008. Ever since then, Filippo has worked with more than 20 countries in Latin America and the Caribbean, negotiating more than 20 grant agreements for a value of over $390 million on behalf of these countries. Prior to the Global Fund, Filippo worked in Kenya, Italy, Sudan, and Peru with UNDP, UNFPA, and the European Parliament. So, Filippo, over to you. Thank you very much.
Thank you very much. First of all, thank you very much for inviting me and also the Global Fund to this important event. South-South cooperation and partnerships are terminology that are deeply embedded in the DNA of the Global Fund, which is a multi-stakeholder partnership involving governments, donors, private sector, and civil society. Globally, we were created in 2002, and since the creation of the Global Fund, many remarkable results have been achieved. We have distributed over 400 million bed nets. We have put more than 11 million people on TB treatment, etc. The initiative that I'm about to present, in a way, represents in a smaller case, like all the partnership that the Global Fund is about. The initiative, it's called Iniziativa para la Eliminación de la Malaria in Mesoamerica and Española, which comprise Dominican Republic and Haiti. It's an initiative, and we like it to call it like that, not a program, to eliminate, as I said, malaria in Central America and Dominican Republic and Haiti. The region itself has already achieved the reduction of 75% of malaria cases. However, there are differences in the epidemiological profiles of many of the nations that are participating in this initiative. Countries have been divided into 3 different strata. There are some countries that are low burden, such as Belize, Costa Rica, El Salvador, and Mexico. Others that are medium disease burden, such as Nicaragua and Panama, and others that have a high disease burden, such as Haiti, Guatemala, Honduras, and Dominican Republic. Why we did pushed for an initiative of this kind? Because the region has achieved remarkable results in the past decades, and we thought that, and we are sure that we can further accelerate this trend toward the elimination of malaria. There has been an ongoing political commitment in the region. In June 2013, through the Council of Health Ministers in Central America, COMISCA, a political declaration was signed by the various Ministers of Health in the region to eliminate malaria by 2020. And potentially eradicated by 2025. There have been national allocations through our new funding model that will be bringing additional funding to fight malaria, and there have been an ongoing external support not only by the traditional actors but also from regional and in-country actors. What were the programmatic gaps that we found at the very beginning when we initially started to sit down with countries and the various organizations that have provided support? In general, I would say that there were a fraction and limited national funding. There were national malaria programs that were more focusing on controlling malaria rather than pre-eliminating and then eliminating the disease. There were some operational limitations due to the mobile populations in between some countries like Haiti and Dominican Republic, and also Colombia and Panama. And there were, like in each country, there were some insufficient human resources, the technical capacity of the human resources. By bringing together all the countries, we realized that it would make sense. It would make sense to instill a perspective of regional ownership in eliminating malaria, because like the elimination of it, it's far more complex if done in isolation. A regional perspective could foster the active exchange of information and best practices among the countries, and we also could enhance a process of harmonizing the national strategies into a sub-regional to eliminate malaria. These slides wants to represent a little bit all the actors that have been involved since the very beginning, from the initial discussions to the planning, to the negotiations of the agreements, and through the implementation of this initiative. Overall, we have 11 countries involved, plus the 15 partners that have whose logo is showed in these slides, and the number of partners we hope will grow in the future. These slides wants to just give you wants to show like what and where like different partners have provided at different times of this initiative. PAHO has provided on a regional level like technical support during the development of the concept note that was later submitted to the Global Fund, and has also developed an innovative data verification methodology that will be based on a data trustworthiness index. This is the first time that PAHO has developed such a methodology. It will be tested probably in 1 or 2 countries in the forthcoming months. And these methodologies will serve to verify if the data on the only impact indicators that the countries will report, which is the number of malaria cases, are trustworthy and robust enough to trigger an innovative methodology based on rewards that we have developed. The Gates Foundation and the Clinton Health Access Initiative have provided and are still providing technical support. CHAI will open 2 sub-offices, one in Guatemala and one in Haiti, to help the Central American region and the island of Hispaniola to eliminate the disease. CHAI will also evaluate the reward mechanisms that it's at the core of this initiative. It's called the cash on delivery. And Bill and Melinda Gates Foundation has recently decided to provide additional funding, around 30 million, for Haiti to eliminate malaria. ISG Global, which is a Spanish think tank, have provided technical support through the organization of regional workshops for decision makers and technicians to change their national strategy from control to elimination. And the CAF has signed a trilateral agreement between the Global Fund, the National Malaria Program in Dominican Republic, to support the country with funding for to strengthen the national surveillance system. Health Focus, through the German cooperation, has provided funding to the regional coordination mechanism, which is a key mechanism in the region, bringing together all the national governments participating in this initiative, the civil society, private sector, etc., to support the work of this mechanism and therefore enhance the regional ownership of the initiative to eliminate malaria. The government of Mexico will provide technical support through the organization of regional workshops on entomology, and therefore to enhance the technical capacity of each country. And last but not least, the Colombian Development Cooperation Agency, through Caucaseco, which is a research center based in Colombia, has not only helped the entire initiative to be developed into a program proposal, but also to organize regional trainings for on a variety of issues aimed at eliminating malaria. Now, when we talk about cooperation and partnership, it's always very good, but it's also nice to try and see not only who does what and where, but also how much funding is being available. One of the goals of this initiative is to be catalytic, not only to bring in new partners, but also to ensure that these partners adequately support the initiative. Overall, like these slides would like to show how much all the partners have so far funded. And if we look at the funding of this initiative, which is 10.2 million, plus all the countries that have already received investments from the Global Fund, plus the external resources that are being made available by a number of actors, overall, the amount of funding available, it's over $100 million. Just a quick word on on how the budget is structured. The 30% of this grant goes on to fund some selected countries with startup funds to ensure that they strengthen their surveillance system. Strengthening the surveillance system means to have more robust data to be verified, of course, but also to ensure that we have correct baselines to trigger the reward payment system. And the reward payment system basically is allocated through a budget of 7 million. Countries, we report the data. We report the data on the number of national malaria cases, and if they achieve impact, they will receive ex post a reward. What do we expect from this reward system, which is a bit different from the traditional modus operandi of the Global Fund? I would say that the most important part is not the funding available itself. $650,000 of reward per country might not make the difference. But what is making the difference is the way countries are competing with one another to do better than the others. When we talk about malaria, we have to understand that what happens in one country might have an impact on the neighboring ones, because populations are mobile, and therefore the number of malaria cases might increase in a country if population from a country moves to another. So I would say that the key point for the reward system is the fact that it has triggered a sort of healthy competition amongst the different participating countries to cooperate with one another, but to push one another to do better. And these last slides, it's just the timeline. I want to show you the timeline, but as a matter of fact, I would like to focus on the fact that since the planning, the 5 initial dialogues that we had in 2013, through the design of the proposal, through the implementation, the disbursements of the startup funds to strengthen the national surveillance systems, and in the future, wants to show you that how all the partners and all different actors have been actively involved, and our role as the Global Fund has been to try to push and to facilitate all this process, which hopefully by 2020 will lead to elimination of malaria. Thank you very much.
Thank you very much, Filippo, for that very interesting presentation, looking at cooperation. Really, that kind of is across a sub-region with the support of financing agents and the International Cooperation Agency and specialized partners. A very interesting initiative. I'd like to now pass or invite Dr. Neves, Maria Simões, to speak. I think Dr. Simon is about to give us a short intervention on a project that is being financed by JICA. Maria is a specialist in public health. She's the head of the Public Health Department, Provincial Directorate of Health in Luanda in the government in Angola. She obtained a master's degree in public health and health management from the Andalusia School of Public Health in Spain. And since 2006, she is the head of the Public Health Department.
Thank you. Good afternoon, everybody. Firstly, I would like to thank for the opportunity that you give us to share our experience. Our project is a project for strengthening health systems through human resource development in 2 referral hospitals and other health service and revitalization of primary health care in Angola. The name of the project is Pro Força. In Portuguese is straightening. Is an example of triangular technical cooperation between Angola, Japan, and Brazil. The period of the implementation was from October 2011 to October 2014. The counterparts are Ministry of Health of Angola, Japan International Cooperation Agency, JICA, and Brazilian Cooperation with the Oswaldo Cruz Foundation and the University of Campinas. Our situation in Angola, our population is about 24.3 million of inhabitants. Our mortality rate is so high, and also the under 5 mortality and infant mortality. The health access is about 79.2%, and the major causes of death are the transmissive disease like malaria, acute respiratory infection, and diarrhea disease. What's our challenge was to improve skills of human resources in those people who works with the mother and child health, to improve monitoring and evaluation system, to improve community participation, and to reduce infantile and maternal death. Our overall goal is quality of healthcare in Angola improved, because this project was implemented in Luanda, in the capital, who has the 30% of the population. The project purpose was to improve quality of health care in Luanda province through strengthening human resources. Our target, primary care, is our priority. Mother and child care, by implementing a tool with the MSH handbook and the tertiary care, because those unities of the primary care, they refer to the two big hospitals. And in this project, 1,055 health technicians were trained, which results in the primary care results. You achieve the internal organization of health unity, organization of reception and archive, organization of clinical history. Maybe you are looking there. This is our MSH handbook. Before you had two tools, one for the mother care and another for the child. Now you have a new tool with the care for the mother from the conception until the child with 5 years. Our results, before you constitute a commission for MSH handbook with making a draft, for the handbook, a draft for a manual, technical guideline for use of this MSH handbook. You also implemented and evaluated a pilot implementation and making a strategy for implementation for the national level. And I suppose I expect to extend to the national wide from the beginning of 2016. At the tertiary care, you also have some results. Nomination of management body which support general director, establishment of roles and routines in the two hospitals, better integration of all sectors, and you have some factors of success, like initiative of the Ministry of Health. You can see in this picture, they are the Ministry of Health and some authorities and some members of JICA organization. Have good monitoring, including all project members, empowerment of each health unity, and action of support site is to facilitate the sustained effort of Angola, sharing good practice and experience of each country. This is the last one. Thank you for your attention. Please.
Thank you very much. Thank you very much for that very interesting presentation. So now comes the fun part, the part where we get to provide comments and ask questions. I think we've really seen 4 very interesting presentations, different experiences, projects that are scalable, either within the region of the Americas or within between the region of the Americas and other regions globally, or between countries across the globe. I'd like to start off the questions by asking the panel, and I think I'll ask Mariana to try and tackle this one. We've seen that all the projects present a very positive picture of South-South and triangular cooperation in health. But what do we see are the challenges? We haven't really seen any particular challenges in negotiating some of these agreements. And what are the risks associated with moving in this direction for South-South cooperation?
Okay, thank you. We could have a whole afternoon discussing this, but I'm going to try to be brief. I think that challenges, when we think about South-South cooperation in general, I would say that we should learn from past mistakes and try to not replicate old models, meaning that we have seen many other types of cooperation when actually they are not based on reciprocity or teamwork. And I don't understand that South cooperation should have donors or recipients, but we should have countries working together, institutions working together. Dr. Simon Blend gave us a very good, 2 very good examples on how we can learn from countries that we have never thought that we should or we could. So there is no one in the world that is too smart, that has nothing to learn. And then in the opposite side, there is no country or no society or no institution that is too small or too new that has nothing to teach. So I think that, in my opinion, is the biggest challenge for South-South cooperation, to build its own pathway. Of course, looking back and not making the same mistakes. Of course, we're going to make our own mistakes, but they should be based on values that we have learned since the beginning of this Expo. I've been here since Monday, and I have learned many times the word solidarity, the words harmony, and in health, just to close, I think that we should be looking at strengthening national capacity, because we have seen many times, if we look back, that we have had great programs, and I like that Dr. Iaheda said that they prefer to call it an initiative than a program, because we have had good programs from interesting initiatives on cooperation, but those initiatives did not build national capacity. So what happens is, when the donor country or the supportive or the partner, whatever we want to call, goes back, when the program finishes, we go back to the beginning. So it's very important to strengthen national capacity in health and involve, as said before as well, private sector and civil society. Without those, we won't advance in health nor in South-South cooperation. Thank you.
Thank you very much. Is there any question from the audience? Yes, please. If you could introduce yourself as well. Thank you.
Thank you very much, and congratulations to the panelists for an inspiring set of cases that were presented this afternoon. My name is Bobby Olarte. I am from the United Nations Population Fund, and I have a specific question on the triangular cooperation structure of the case of Angola, Japan, and Brazil. Actually, I just would like to know a little more of the specific contribution of Japan and Brazil in this triangular cooperation, in terms of what is the specific knowledge shared by Brazil, as well as is there a financial contribution of each partner as well? Thank you.
So before we pass over to the representative from Angola, is there any other comment? Yes?
Good afternoon. My name is Chioma Onukogu. I work with the African Development Bank. I have a quick question for Filippo. Thank you for the presentation. But I noticed that of the $10.2 million for the initiative you presented, there's $2 million earmarked for grant management. Could you explain that, please, and what it's really for? Thank you.
Okay, so I'll pass it over to the panel. Maria? If you'd like to. Yep.
Thank you. For the contribution from each country, from Japan, you receive technical assistance and also equipment for the primary health care and the big hospitals, and from funds for capacitation, because people, some profession went to Japan for training, and other people to Brazil for training also. And from Brazil you receive also technical assistance to Angola and for capacitation people in the two levels, for the primary care and the tertiary care. So from Angola, our contribution was with the budget, national budget, to rehabilitation the infrastructures and the equipment of the infrastructure, also support for travel and conditions for all the capacitation in the country, and also some contribution outside the country. But I'm with some people from JICA if they want to say something more. It's good, I know. Because the number, I didn't bring with me the number of funds, but it's similar for each country. It's also.
It's my turn. Thanks for the question. Yes, as you have noticed correctly, we have allocated 3.2 million, of which 1.2 will go to finance governments with startup funding for to strengthen their national surveillance systems, and then we have also earmarked 2 million that they go. I put them as for program management purposes. If you know a little bit about the model of the Global Fund, usually we sign grant agreements with principal recipient, which is in this case PSI, which will disburse the startup funds. But then the 2 million specifically will go mostly to ensure that the countries will get together to set up a regional strategy to eliminate malaria, but also in country to help them in changing their strategies from control to pre-elimination, or from control to elimination. Of course, part of this money will also go to support the human resources of the PR. The PR have to, the principal recipient had to hire some malaria specialists that they are traveling quite extensively in the countries, and hence are paid through this money earmarked. Thank you.
Okay, are there any other burning questions? Yes, please go ahead.
I have a question for Mariana Faria. In ISAGS, there are 12 countries, which is a relatively manageable number of countries to meet and discuss. But within South America, there's so much variety about the role of the state in the provision of healthcare. So can you tell us a little bit more about how you actually get to cooperate?
Okay, and I think there was one more question at the back. Yes, if we can, we'll have to take it.
I think I didn't introduce myself, did I?
No.
Arachu Castro from Tulane School of Public Health and Tropical Medicine in New Orleans.
Thank you. And this will be the last question.
Yeah, I'm Rosina Salerno from PAHO, and my question is looking at the future. What space do you see for technological innovation in the cooperation, thinking of telemedicine or e-mobile medicine for the future of South-South cooperation? Thanks.
So Mariana, perhaps you can take the first.
Okay, yeah, I think the first word would be respect. We respect each other, and it takes time. UNASUR is an integration process, so it's ahead, or it is different from only South-South cooperation, because when we have South-South cooperation, of course we need respect, but there is a focus, and we can agree on that specific matter. But in an integration process, things go deeper, of course, because the idea is to have a South American identity and to strengthen the subcontinent as a global player in many areas, including health. So I think it's respecting. Yesterday I learned TTT, which is, I don't know if some of you were here, things takes time. So I took this to myself, and I'm going to use it many times now. And so I think transformation, we could change the first T for transformation, also takes time, and integration and cooperation as well. So I would say respect and time, and I think when we have something that we truly believe, and I think that is, UNASUR was built on that. The possibility that we could reduce or even eliminate, which I think it's a very high standard, but reduce inequities in the region. And so that's what 12 countries got together. And so even though they are different, they have different laws and different roles for their states on health and other matters, they do believe that together they will work better on reducing inequities in the region.
And David, I'd like to ask you perhaps to say a few words on the issue of innovation.
Yeah, well, we have, as Mariana said, we have a very different regulation frameworks. It's very difficult, as in the presentation I said, there are some basic issues that we didn't resolve yet. So, but there is a tool from PAHO now in the medical devices that is developing, and also we are working each country in our biologics and biosimilars frameworks. I think we need to start with the basics, but we need to keep going in developing this kind of tools in the most innovations, medical devices, and the new medicines that are coming to our agencies.
Okay, so thank you very much. We've reached the end of our panel on global health and South-South triangular cooperation. I would just like to close by really thanking all the panelists. I think the experiences and the projects that we've listened to here today really do speak to the value of South-South cooperation and some of the recurring themes that we've heard through the presentations. It's obvious that South-South cooperation really requires a strong political commitment from the countries that are involved in it, and we saw that clearly in the presentations. There is that element that was highlighted from a question from the floor and what David was talking about, the innovation. There is innovation in health through South-South cooperation. It builds knowledge, it shares experience, and it seeks to innovate in terms of the types of strategies and technical cooperation that is being delivered. And this is really, I think, remarkable given the diversity of countries in terms of economic development levels, socio-economic characteristics, culture, that there is such vibrancy in terms of South-South cooperation. And I think we can just say and finish by saying South-South cooperation in global health is alive and well. Thank you very much. So I've been asked now to inform you that the second panel will commence, and I have the pleasure of handing over the moderation of that panel to Dr. Green, who's a Special Envoy for the United Nations Secretary General for AIDS in the Caribbean. And so if you could remain in the hall. Thank you.